Hello, I am Amy Nat. I am the CEO of Aging Outreach Services, and this is All Things Aging.
And I'm Amy Phariss, editor of Outreach NC, which is our monthly publication that we put out each month about all things aging. And today we're talking about palliative and hospice care.
So we're super excited to have a guest on the show with us today. We have Dr. Timothy Beittel, and he is the director of Hospice and Palliative Care at FirstHealth of the Carolinas. So he is going to answer some of the frequently asked questions about palliative care and hospice and share those resources with us. We're going to link his full bio down in our comments, so be sure to check it out.
So welcome, Dr. Beittel.
Good afternoon. Thanks for having me.
Thank you. And thank you for coming to talk about something that I think is something we've all heard about, but often have misconceptions or misunderstandings about, which is palliative care and hospice care.
Yes, indeed.
So let's get started with what are each types of care? How do you define them?
Well, the one people are probably more familiar with, since it's been around longer and is better defined, is hospice, which has been for decades now a service that's provided under Medicare coverage, and then most state Medicaid programs and private insurances have a similarly modeled program. Started with the inspiration of Dame Cecily Saunders in the UK in the 1960s. Took a while to come over to the States and become adopted into normal practice. But it is care that is specifically for somebody with a terminal diagnosis that's expected to be in the last 6 months or so of their life. So a physician has to certify that, to their best judgment, more likely than not, they will probably pass within 6 months, and then they would qualify for hospice care. And it's a well-defined set of benefits that Medicare offers. So a person has to be covered by Medicare and Part A. It replaces their normal Medicare coverage and provides all of the services related to the care of their terminal diagnosis, as well as taking care of any symptoms related to that diagnosis specifically, or to the dying process, the end-of-life process in general. We can probably get into more of the specifics later on.
Okay.
But that's sort of the key there, is services for somebody that's in the last 6 months of life.
Okay.
The palliative care is a little more amorphous, nebulous, less well-defined. So we run into a lot of folks that don't really, even other medical providers who don't really understand exactly what it is. And that is a service that is really aimed to help palliate or relieve or help care for troublesome symptoms for anybody really that's got a serious, usually chronic, but it could be an acute issue, a diagnosis that is interfering with their comfort and their function and likely to have an impact on their life. And it has no time limit.
Okay.
So it can start any time as soon as a person becomes aware of or is diagnosed with that kind of serious problem. And it aims to help with those symptoms regardless of exactly what the cause is or whatever else might be going on with the patient. Again, we can get into some more specifics later, but that's the broad distinction. Is hospice is really designed for folks who are in the last 6 months of life. Palliative care can happen, has no particular time frame, can happen at any time for anyone with any significant serious illness that's impacting their life. And we can talk about the things that it would help them with.
So with regard to timing with palliative care, just as soon as you get a diagnosis, are you looking at that? Or is it when it starts impacting your daily life? What would the timing look like?
Well, theoretically, it could be any time after diagnosis, but sure, it makes more sense that it's going to have a greater impact for folks and be something that people think about more when it is having an impact on your life. But that being said, if it's a diagnosis, just taking one of the most common, for example, a type of cancer that you already know up front is likely to have a limited life expectancy or have a particular symptom burden as time goes on, there's nothing stopping palliative care from getting involved early on to help educate the patient and their family about the disease and the likely course, and to start to plan for what's going to come. Make sure that they have appropriate medical care providers on board, caregiving resources at home or wherever the patient is located, that they've made financial and decision-making plans for their future, advanced care documents such as living wills and powers of attorney and so on, connecting with community resources, support groups, aging outreach services, things like that. That's what palliative care is specifically designed to help with. And really for both services, whether it's palliative care that can happen at any time, or for hospice for those folks that have been determined to be most likely in the last 6 months of life, really getting involved sooner is better. The earlier, the better. It gives the care team, the palliative care team or the hospice care team, more time to build relationship and trust and understand everything that the patient and their family need and value and how they want things to go in their journey, and to be able to provide as much support as possible. You can imagine it's tough if you're just coming in at the very last minute trying to meet, and on both sides, for the care team to meet and learn the patient and their family, for the patient and their family to meet all these new care providers, not have the time to really do that in a meaningful way.
Sounds like it can help prevent burnout on the parts of everybody.
I mean, that's one of the, especially for hospice care, I mean, that's one of the specific stated goals, is to help reduce caregiver burnout, provide some of their specific parts of the hospice benefit that are designed to provide some respite for them, breaks for them, so that they can attend to themselves and in turn then not get sick or burned out, and continue to be available to provide care for the actual patient.
And it sounds like these programs kind of take everything off of their plate and let the family member focus on it being with their loved one instead of having to think about all of the logistical concerns.
I would never say it takes everything off their plate. Obviously, the burden and the duties of being a caregiver for a seriously ill or terminal patient still continue. But yeah, we try to take as much as possible off of their plate so that they can have, the time to be a family member, be a loved one, be with them, and have some meaningful quality time together.
What are the specific services involved in each type of care?
So again, hospice is a very well-defined Medicare benefit. So it is care, again, for somebody last 6 months of their life, and it's provided by an interdisciplinary care team. And Medicare has specific requirements for who's on that team. There, of course, is a physician and potentially other medical providers, other physicians or advanced practice providers like nurse practitioners or physician assistants. There are nurses that provide care. There are social workers. Everybody in hospice has at least those three disciplines that are working together on their care: the medical providers, the nurses, and the social workers. The broader interdisciplinary team also has to include chaplains and other spiritual care providers, volunteers and volunteer service coordinators, and of course home aides, personal care aides, nursing aides that are providing kind of direct care or assistance with daily activities for the patients. They're on the team that meets regularly every 2 weeks to discuss all of the patients, whether they are directly involved in each patient's care and going out to the home or wherever the patients are located, like the other disciplines, depends on whether they need those services at any given time. And for those who may have even more specialized needs, we can provide therapy like physical therapy, speech therapy, occupational therapy, music therapy, activity therapy, art therapy, all those kind of things. And like I said, there's a defined schedule of meetings. The team meets every 2 weeks to discuss the patients, and then the nurses are going out. At a minimum, the nurse is seeing the patient every week or two, but that can be much more often, if there are actual symptom needs, changes going on, additional help that the patient and the family need. Palliative care, on the other hand, again, is really more of a consultative service like other specialties you might think of, like cardiology or neurology. And at a minimum, it is going to include a medical provider, whether it be a physician, nurse practitioner, or physician assistant, who is seeing the patient, doing an assessment, helping them with medical decision making, possibly prescribing medications for them. Beyond that, again, there's nothing that's specifically defined by Medicare, but in its ideal state, it is also provided as an interdisciplinary team service similar to hospice. And many palliative care programs, including the one at FirstHealth, will include nurses and social workers in that as well. So nurses can do follow-up visits with patients after the provider has seen them and made some med changes to see if their new pain medicine is working or something like that. The social workers can be the ones who, of course, are most versed in connecting folks with resources like yours in the community, and also helping them navigate the medical system itself, which, as we know, can be very complex, can be difficult even for those within it to understand. And especially for somebody with a serious illness and a family that's feeling overwhelmed, they may not know the best providers to see, the right specialists to be involved, how to get certain tests done or appointments made or transportation arranged or any of those things. And the palliative care team, again, that they're there to help be a support and assistance and a sort of patient navigator, a family navigator for that. Particularly robust programs may include many of the other things that hospice programs usually do, such as therapists, volunteers, aides, and so on.
What are some of the things volunteers do?
It can be almost anything the patient or their family want or are interested in. Probably most typically, in part, it's sort of a respite for that caregiver. So especially for a patient that maybe is so dependent or so impaired that they can't be left alone for safety reasons. Obviously, that's particularly wearing on caregivers if they have to literally be there 24/7. And all of the different disciplines that are making visits in hospice that can provide some relief while they're there. They can be monitoring the patient and give the primary caregiver or other family or loved ones a break. But having a volunteer come provides some additional time that someone else is watching out for the patient, and the loved one can step aside, take a nap, get a snack, do some shopping, get out, whatever they need to do, be outside in nature. And while they're with the patient, usually they try to identify what the patient's interests are and play to them. If they like to be read to, they can do that. If they like to reminisce with pictures or scrapbooks, they can do that. If they like to listen to music, they can do that. If they are able and they like to go, outside in the garden or whatever in nice weather, they can take them outside. Some specific things that we often pay attention to is for our veterans who are interested in being recognized for their service and may feel like they can particularly form a relationship with a fellow veteran. We try to hook them up with a veteran volunteer specifically to give them that recognition and companionship. They can do some basic things around the house. I mean, they're not really supposed to be, housekeeper or cook or anything, but they can help get snacks or, again, whatever the patient likes to do.
Where does care take place?
Most commonly in the patient's own private home, whether that be a house, apartment, mobile home, wherever they live. For those who are in a facility, like an assisted living facility or nursing home, that's considered their home at that point, and care would take place there. Some programs, especially in major cities specifically, try to do outreach even to homeless folks and provide care on the streets, wherever, again, it's where the patient considers their home. Medicare, so that's hospice, by the way, in case I didn't say that specifically up front. And Medicare recognizes several specific levels of care as well. Routine home care, which is what I just described, taking care at whatever that location is that the patient and family consider their home. They also offer respite care, as we mentioned. So besides just the regular visits to the home from all the different disciplines that may provide a break for the caregiver, they get 5 days each of their benefit periods. In hospice, patients get 2 initial benefit periods that are 3 months each, so that comes to 6 months, which sort of aligns with that 6-month life expectancy that they're expected to have. But even after that, if a physician continues to certify that they are most likely still now, because of what's going on within their last 6 months of life, they can continue to get a limitless additional 60-day benefit periods.
Okay.
And in each of those benefit periods, they can have 5 days of respite care, which takes that patient out of their regular home into either a inpatient facility like a nursing home or an actual hospital floor that's designated to provide that service. Or as in the case with FirstHealth Hospice, we have our own dedicated inpatient hospice facility on our hospice campus in West End, and provide that respite service there as long as a bed is available. But even for hospices that don't have their own dedicated facility like that, like I said, every hospice is required to have somewhere they can provide that respite care. So they would have a contract either with another hospice that has that facility, with an acute care hospital that has space for it, or with one or more nursing homes in the area that could provide that service. So the patient would go and live at that facility for those 5 days, and that gives the caregiver a more of an extended break. And that's, of course, especially good if folks have to go out of town,
right.
For something, for a family wedding, for some other event that's important to them.
And what about palliative care?
Palliative care, again, can really be provided in all the same places with some additional options. There are palliative care services that go out to patients' homes, again, whether that be a private residence, nursing home, or assisted living. There is palliative care provided in a dedicated outpatient or ambulatory clinic like any other doctor's office you would go to. And then there is also inpatient palliative care at most major medical centers these days. And FirstHealth has all of those. We do go out, assuming the patient is close enough to our main campus to providers to reach easily, we will go to their home. We have a palliative care clinic that is located in our brand new cancer center in Moore County. And that's nice, especially because it's right there with all the oncologists' offices as well. So when folks come in, since that is one of the most common diagnoses that folks may need palliative care for, is a cancer diagnosis. When folks come in for their oncology appointments or for their infusions or labs or other treatments, they can have their palliative care visit right at the same time and not have to make a separate trip. And it also makes collaboration between the palliative care folks and the referring providers better. So we have that. We have FirstHealth has inpatient palliative care at their main hospital, more regional, in Moore County in Pinehurst. They have a satellite clinic in Richmond County, and we also do telemedicine palliative care through video conferencing or phone calls.
I bet that would be
for folks that need it.
So if you go inpatient with palliative care, would it be something like you have a condition and you need stabilization, or maybe you've had surgery related to it, something like that?
Good question. People don't normally get admitted directly to the palliative care service or for palliative care. It is, again, it's a consultative service within the hospital. So whoever has admitted that patient, whether it's a primary care provider who has their patient in the hospital, or an oncologist, a surgeon, or other specialist, whether they already knew the patient up front or the patient came in with a new acute problem and was now diagnosed with cancer or serious heart or lung disease or some other potentially terminal illness, and they feel they could benefit from services from palliative care, they will then consult them, and our inpatient team will see them while they're in the hospital. In the hospital, it's often aimed at, again, trying to make those connections with community resources to make sure they have an appropriate discharge plan in place, making sure they have appropriate advance directives in place. If it seems like somebody that may, in fact, be eligible for hospice, having a discussion about what that might look like and seeing if they want to go that route when they are ready to discharge, or just getting to know them and, passing them along to the outpatient palliative care providers when they're discharged, if they're not at the point where they are eligible for or ready for hospice.
Todd, so you've mentioned Medicare a couple of times. Is private insurance involved at all?
Yeah, again, so of course, with the population we're dealing with tending to be older and with multiple chronic illnesses. Of course, most of the folks we're talking about are Medicare, or potentially on one of the common Medicare replacement plans, like different Medicare Advantage plans these days. But all of those Medicare replacement plans have to provide the same services that Medicare does, even if they have slightly different ways of paying for them or financing them, but they still have to provide them. So again, anybody that has Medicare or Medicare Advantage and any Medicare replacement plan would be eligible for hospice. But like I said, when we started, most state Medicaid plans and most private insurance plans also have a hospice. Even if they don't even specifically call it hospice, they probably have some sort of end of life benefit that is modeled very closely, if not exactly, after Medicare.
Okay. So it's worth looking into your insurance.
For palliative care, again, that's handled by Medicare and most insurances, again, like seeing any other specialist.
Okay.
So most Medicare and most plans have sort of a copay, if you will, or a set of deductibles or co-insurance that is attached to you seeing a primary care provider, and then usually a different, most times somewhat higher copay for seeing a specialist like a neurologist or a cardiologist. And it would be the same in most cases for palliative care. So whatever your specialist copay is, that's what you would have for each visit with the palliative care. Now, in some of the newer, what we call kind of value-based care arrangements, like accountable care organizations or things like that, they may have different ways of financing it. And some plans may actually offer palliative care as part of a suite of services that may not even have any additional charge to the patients. It just depends. It's very dependent from plan to plan, whatever your insurance plan covers.
Okay. What would you say is the biggest barrier to people receiving these services?
Well, one is knowledge, just being aware that they exist and sort of understanding them and not being scared of them. Like I said at the start, most people by now at least have heard of hospice and are sort of familiar with it because it's been around a while. Medicare clearly defined it, and like I said, most plans have copied the same sort of benefits. Palliative care, on the other hand, is still less well known, again, even amongst other medical providers, unless they happen to be somewhere at an institution and in a specialty or sort of day-to-day work where they come into regular contact with palliative care folks. Just getting the word out and letting people know like this, what the services are, that they're available, that's a big step.
Yeah.
But even when the services are around and people know about them and they're offered to somebody, patients and their families, and again, even some medical providers often have sort of misconceptions that make them fearful or reluctant to engage in them. Having that extra attention from hospice and the extra touches, the extra eyes on, hands-on care, paying attention to their needs, looking at their medicine list, optimizing it, and so on, that they really start to do a little better. And we often see a sort of hospice honeymoon or hospice holiday, and people can live for a while. And of course, like I said, although you're supposed to be certified as being in that last 6 months of life, that's not an exact science deciding that. And many people probably know a lot of people who have lived longer than 6 months on hospice, and sometimes for years. And in fact, if people stabilize or get better enough, they can even, quote, graduate from hospice or get discharged from hospice. Now, obviously, we're all going to pass at some point. So in most cases, we're going to get those people back on service if they're interested when the time comes. But they could be discharged and have some period of time where they're out on their own again.
So it sounds like it really helps improve quality of life, actually, both for the patient and caregivers.
And most people will say it was such a blessing when you ask them either during or afterwards. And palliative care in particular can help to make that bridge for folks who are reluctant to think about hospice, to think about the fact that they may be getting close to the end. or what that might entail. And people who may not be ready to sign up for hospice may be willing to have that palliative care consult where a trained provider who's used to having these kinds of discussions can come in and, again, kind of assess their understanding of where they are in their medical journey and their life journey, what their needs are, what their symptom burden is, and start to talk with them about planning for what is likely to happen in the near future and what hospice services really entail and whether or not it'd be right for that patient and family who would be eligible for hospice, which is a big point, and this can be a sticking point. It could be a barrier too, as we talked about, is hospice does focus on that comfort and symptom management at the end of life and really is not designed to continue to do a lot of aggressive testing and treatment aimed at diagnosing new issues or curing or eliminating disease. So at least in most settings in the United States these days, to be on hospice, you do have to have at least some acceptance that you're not pursuing aggressive care along those lines anymore, and that you are ready to, the goal is to keep you at home, keep you out of the hospital, sort of demedicalize as much as possible the end of life, so that you're spending time at home and with your family and loved ones, not in a hospital, not having a lot of tests and treatment. In the VA system and some specialized plans like certain accountable care organizations, they may have what's called concurrent care, where people can actually still receive hospice care and aggressive treatment together, but not in most Medicare.
Okay.
Versus palliative care that specifically goes along with all the other medical care that you're continuing to receive.
That's a good distinction. All right. Thank you very much. I appreciate all of the information and the way that you've explained it in a way that we can understand.
Again, thank you for having me.